Okay, so as it's now 5:05 p.m., we're going to be starting the webinar. Hi, everybody. My name is Alan Steinberg. I'm the Assistant Director of Enrollment here at NYCPM, and I'm very lucky to be joined tonight by Dr. Russell Volpe, a specialist in the podopediatric field. He's going to talk to us tonight about podopediatrics, how it differs from adult medicine, and give you a general overview of his specialty. We will have sections for questions. So if you have any questions, either write them down or put them in the Q&A chat. Yes, Daniel, this is being recorded. We will send out the recording as soon as we finish editing it and all that sort of thing. And yeah, if anybody has any questions at all, I'm just gonna start the webinar by putting this here. Please email this email inbox, and someone will get to you and answer your questions or provide you with whatever help you need. So without further ado, please, Dr. Volpe, take it away.
Thanks, Alan. Hello, everyone. Welcome to our NYCPM webinar on the podopediatrics subspecialty of podiatric medicine. And not sure why, Alan, if you're listening, why are my slides not advancing?
I think it's a problem on his end because he says his speakers are not exactly in a good state.
Say that again?
I think it's on his end.
On whose end?
On Daniel's end, the person who said that. But is my microphone okay now?
Yeah,
Guys in the chat?
but I said to you, I'm not able to advance the slide. So here.
Oh no, it just sometimes it takes a little bit.
Okay, so everyone's hearing me. Are you hearing me,
Yes.
Alan?
Yes, I can hear you. Everyone can hear you.
Hi, everyone. I'm a pediatric specialist and I teach pediatrics on the NYCPM faculty for nearly 40 years now. You can see some of my CV and credentials there on the screen. I've been teaching and working in the pediatric subspecialty since the mid-1980s, and I do a lot of lecturing and writing and teaching on pediatric topics. So what the admissions and recruitment team at NYCPM asked me to do was to offer you a little bit of an overview of what we do in podopediatrics, and hopefully will give some of you an idea of what the specialty of podopediatrics is like, and perhaps encourage an interest in this as a career path for some of you going forward. As you know, podiatric medicine is the specialty that is the specialty of medicine that concentrates on the foot, and all podiatrists treat the foot and the foot and ankle in some cases, depending on state law, and within the specialty of podiatry or podiatric medicine, there are various subspecialties. People concentrate in different areas: orthopedics, biomechanics, dermatology, wound care, surgery, and so on and so forth. And podopediatrics is one of those specialties. So I basically treat a variety of foot and leg conditions in children, typically under 18. In some clinical settings, it goes a little older, but it's primarily those under 18, and there are lots of patients in that age group that need us. So these are some of the reasons why a podopediatric specialist is valuable, because they have additional training beyond that of the podiatric physician, and they learn through their specialized training how to deal with the specific problems of infants, toddlers, children, and adolescents, and that makes them a good fit. And certainly, as a specialist, you attract certain referrals because of that additional expertise you have above and beyond the generalist. And with that experience comes the ability to evaluate, treat, and work with pediatric patients and their families. And then many of us working in the subspecialty have academic credentials. Someone like myself who teaches pediatrics full-time at one of the podiatric medical colleges has the ability to combine academics and clinical practice, and that can enhance the ability of the specialist to provide the services and be a great resource to both children and their families. So what I have here prepared for you is a sampling of some of the pathologies that we typically see in pediatrics, and we'll give you a little bit of a flavor of the variety and the kinds of things that I see as a podopediatrician. There are many more than just what's on here, but this is a little bit of the highlights, if you will, of the podopediatric practice. First, and perhaps foremost, because it's what children are born with, is the group of conditions that are called congenital, which means that they are conditions that a baby is born with, and they typically present in the early weeks of life, and they are always some of the most valued and opportune patients to see, because we have the ability in the infant before they are weight bearing and walking to guide the foot, correct the foot, fix the foot, so that by the time the foot needs to reach the ground and support weight, it's in an optimal position. So there are many scenarios where the best referral and the best pediatric patient to see is the youngest, because here we have the greatest opportunity to identify and treat the problem. There are many kinds of congenital deformities. These are some examples of congenital deformities of the toes. They can include having too many toes, which is known as polydactyly. They can be toes that are short because the metatarsal behind them is short, which is known as brachymetatarsia. And then we have other conditions where toes are fused, where toes themselves are small, or the toes are curved under other toes. And for these various conditions, we may do anything from taping, like you see here in the two right-hand photos. These are taping for clinodactyly deformities, where toes are curved underneath the other toes, and the taping becomes a splint to mold the soft tissue that was congenitally malpositioned into a better position, get the toe out of its curved position, and over enough time, just like a cast would mold a foot to a new position, the taping does something similar. The photo on the left is a baby who was born with smaller toes, known as microdactyly, and we fashioned a special insert for that patient's shoes with what we call a toe filler, to allow them to wear same size shoes and to avoid the problems of irritation in this front portion of the foot that had the smaller toes, and this soft material in the front allowed the patient to have more symmetrical function. Other congenital deformities, these are congenitally curved feet. This condition is known as metatarsus adductus, and it's basically a C shape of the foot. You can see it here. This is in an infant. You can see the C shape where the toes are pointing to the inside. Right, this is a left leg, so it's pointing to the midline of the body. And this is an older child that's retained that C-shaped curvature, where you can see that this whole portion of the foot is inside to the back portion of the foot, and that's known as metatarsus adductus, and it's C-shaped, and it can predispose to poor functioning of some of the tendons and muscles around the toes when you're older, if it persists. So when we see it in young children, we want to identify it and try to straighten the foot so that by the time they're weight bearing, the muscles are pulling more evenly, and we can avoid some of the problems before they happen. And this is how we do it. We may put casts on, or we may put special shoes and braces on the foot in the infant age group to try to straighten it. This is a particular kind of shoe that's an articulated shoe. You can see here it has a joint on the bottom, and we're able to set this joint to move the foot laterally or outward to reverse that inward curvature. And the patient wears it like a splint, like the toe splint we just saw, or other things. And because the baby is young and the foot is moldable, it's easier to move the foot over. Generally, these congenital deformities, all of them, are best treated when they're young. So the earlier you get them, the better and the easier they are to treat. So this is treating metatarsus adductus with an articulated shoe. There are some congenital deformities of the rear foot or the back of the foot, the heel area, and this is an example of one of the most. This is an example of one of the most common ones. It's known as a club foot, and that's a down and in foot. And you can see it here in a newborn where the foot is facing inward, facing to the midline of the body. There's the baby's other leg. This looks like a bilateral club foot on both sides. And here you can see the downward portion of the foot. And then from the back view, you can see the inward or inverted position of the heel. This is an inverted right heel. This is an inverted left heel. But you have the inward pointing, you have the inward curving, and you have the downward pointing. And that's what's referred to by multiple components here. And this is typically a stiffer foot. The one you saw before is a more malleable foot, so something like that articulated shoe is easy. It's pretty effective at treating it. But these are generally very stiff feet, and they often need a more aggressive treatment in order to correct them. The other thing that's interesting about club feet is that they're often one component of a child with a larger problem or syndrome. So when we are evaluating an infant with a club foot, we want to make sure that it's a club foot in isolation and not a club foot as part of a larger syndrome. And having the child evaluated by pediatrics or genetics or neurology can help us to determine if more might be involved. Again,
Dr. Volpe, we got a question. Are congenital foot deformities more prevalent in certain areas of the world over others?
Yes, it's not so much geographic as ethnic. There are certain populations where certain congenital deformities are more common. For example, clubfoot has its highest incidence in Hawaiian Polynesians of Hawaiian descent. So that's one region / ethnicity where there's known to be a higher incidence of a particular deformity. So yes, there can be more of them in certain regions and certain ethnic groups.
Thank you so much.
So here you see the articulated shoe on the forefoot deformity, and in the clubfoot deformity. In the clubfoot deformity, we put casts on, and you can see that in the bottom photo. Here I'm molding the foot to the proper position before the cast is put on, and then here we can see the bilateral casts that are put on to correct this deformity. They're casts that are replaced regularly so that the foot moves to the right position. It's a gentle and gradual process to move the foot over. So that's the club foot that I just talked about. That's what the bottom photos are showing. And the top photo is those the more supple forefoot deformity that can be treated with the shoe. We also, by the way, in some more severe cases, we put a cast on for the adductus forefoot deformity too. So there are more options for treating this condition, the curved foot, than the clubbed foot position, which requires something more aggressive. So still in the category of congenital deformities, this is the opposite. We just had down and in feet, and now we see what's in this. Now we see a so-called up and out foot, and that is a foot that is congenitally pointing away from the midline of the body, and you can see it here nicely in the photo. The foot is up towards the leg, and it's out away from the leg, and it tends to have a lot of motion in the upward direction and reduced motion in the downward direction, and that's what this condition is called. And it's considered a congenital, born with type of flat foot. And if it's untreated, this is going to predispose the child to be flat-footed or excessively pronated when they're standing, and that's a condition that can cause problems. So this is something, if we identify it in the infant population, we want to evaluate for and treat. So this is kind of a reverse club foot, if you will. Instead of being down and in, it's an up and out foot, and needs to be brought back to where it should be in the pre-walking age group. There's a rigid version of that up and out foot. It's called congenital rigid flat foot. It's also sometimes known as a vertical talus or a convex pes planovalgus. Those are the other names for this condition. And you can see that it looks a little bit like the one we just saw, right? You can see there's the flexible one, which is calcaneal valgus, and here's the rigid one where it's clearly up closer to the leg and a little bit out away from the leg. So that these two can look alike, but this one is a baby born with a flat foot that's stiff, flat, and doesn't really move from there. The other one is a very flexible or supple flat foot that moves very easily up and down. So that's how we tell them apart. And this one is more like a classic clubfoot because it's stiff and rigid like the clubfoot, the original clubfoot was. So these two are more similar. Again, these are outward feet. There's a flexible form that we just saw, and then there's a rigid form. The flexible form is more easily treated. The rigid form, like this one, is more difficult to treat and requires casting sometimes, and casting and surgical correction, like we talked about in the case of
Dr. Volpe, real quick before we move on from the congenital deformities, we have another question regarding them. Is there are most pediatric conditions congenital, or like is there any specific kind of condition that makes up most pediatric cases?
So no, there isn't. But congenital is a big unit. We've just spent time on the group of things that children are born with. Those are the congenital ones. We did toes, we did forefoot, we did rear foot. So that's a big unit. There's a lot of what we see is congenital, those congenital deformities, and we also see some of the things we're going to talk about in our remaining time are other conditions that children are born with, but they don't present till they're older and they're walking. So I would say that congenital in general is one of the big groups of conditions we see in pediatrics, but we see all kinds of things.
Thank you.
Okay, moving on. Dermatology of the pediatric foot. That's a big unit unto itself, right? We see children have skin just like adults, and children get skin problems. And there are a whole host of skin conditions that can predilect for the child's foot, but these are some of the most common. Certainly, by far and away, the most common pediatric condition that I see, skin condition, is an ingrown toenail. Most of the time on the great toe, on the big toe, but it can be on other toes, but the vast majority are on the big toe, on either the inside or the outside of the big toe. And they can present in various forms, where just the tip of the toe is hurting with nail, or sometimes it's the whole side of the nail. Sometimes it's been there for a while and it's now starting to get infected. And there are various procedures that we can do, from a simple slanted cutting of the nail to try and remove the so-called offending spicule or portion of the nail that is ingrown into the skin. And sometimes we have to take a bigger piece of nail out in order to do the correction. And oftentimes to do those, we have to give them a block or an anesthetic so that they can tolerate the procedure. And that's probably one of the most common dermatology conditions we see. Another big one is other conditions of the nail. You can see here, these are fungal nails here, and you can see these are other different conditions of nails that may need treatment, may need evaluation. Sometimes nail changes are associated with other medical problems, and they can be windows, if you will, into finding out that something else is going on. So we may see changes in nails and have to either evaluate them further or treat them. And another very big unit in dermatology is warts, also known as a verruca, which is a viral condition of the skin. And this is a wart or verruca on the side of the toe. And here we've done what's called debriding it, which is to take off the hard callus that forms over it to get to the root of the verruca. And typically you'll see pinpoint bleeding. That's the red dots there. And then we've applied a caustic salicylic acid pad here. It's an acid cream that's put inside of a padded border so that the normal skin around it is protected, and we use the application of the acid to desiccate or destroy the wart over a series of visits. Sometimes the warts are cut out. Sometimes warts have laser treatments on them. Sometimes this cryotherapy is applied, which is a freezing therapy. There are many treatments for warts, but they're common. Warts can become painful, over time. They develop thick calluses on them, and if they're on weight-bearing areas of the foot, they can hurt. And kids are not happy when they're in pain, and neither are their parents. So they often come in to have them treated. And warts, being a virus, can spread. So a child who has one wart, who ignores it or doesn't treat it, can have 5 or 10 warts in a few weeks. Not always, but that's one of the reasons to treat it, in addition to the fact that they can be most uncomfortable. Here's a little bit broader view of some of the skin problems. Atopic dermatitis and eczema are related. They're kind of allergic type of skin reactions. This is an example of atopy here on the second toe, a type of eczema. And blisters are common, often in the back of the heel and other areas. And these are other viral conditions. A flaking condition of the skin is called xanthum, and some of them are viral in nature. A melanocytic nevus is a darkening of the nail bed, and that's a normal nevus, but it can sometimes cause concern because it's brown looking, and parents are justifiably concerned about potential dark looking skin conditions, and they may come in to have them evaluated. And then there are some more unusual things like herpetic whitlow, which is a viral condition that can happen on the toes and can be a complication of associated with ingrown toenails, and that can require special treatment. And then something really obscure like epidermolysis bullosa, which is developing big blisters and bullae all over the body and often on the feet. So the bottom two are very rare, but just to give you an idea of how many different types of skin conditions we see. The ones on the prior slide are the common ones, and these are some of the less common ones, but it gives you an idea of just how many different skin conditions we see. Now, this group of problems are some of the other congenital things that I was talking about before, but now we're moving up into what we call rotational deformities. And these are things that are going to cause children to be pigeon-toed or out-toed, right? In-toe is pigeon-toed, out-toed is when the feet are pointing away from the body. These are all examples of inwardness, and they are significant. They can cause tripping and falling. They can cause pathology in walking. They can cause symptoms. They can cause compensation in other parts of the foot. This is a big component of many of the conditions that we see, and we group them together as rotational gait deformities, but they're basically conditions, and these are conditions that a child is born with. Remember, we said they were congenital. These are congenital deformities, but as children develop, as they grow from birth to around age 7 or 8, a lot of these normal positions that are in when you're born resolve. They straighten with development, they straighten with growth. But in some children, because they were more severe when they were born, or because they just haven't caught up, they will retain these deformities. And when they retain these deformities beyond the age when they should have them, they can develop problems with the deformity, like the walking problems I mentioned before and compensation. So this is a big unit. It's part of congenital, but now we're congenital of the leg. Before we were congenital of the foot. And you can see some pretty inward-looking feet here. These two on the left happen to be parent and child. And there's a genetic component to them. This is the child, and here's the parent with the inward left side. And that's the familial patterns I refer to here. They can be moderate to severe. Mild we're less concerned about, but the moderate and severe ones cause all kinds of problems. And the two big issues are in walking, where you have difficulty walking because of your leg position, and compensation for these problems in the foot, pedalus foot, so foot compensation. And out-toe is when the feet are pointing out, and I see a lot of kids with in-toe. I see less kids with out-toe, but that's another component. Generally, out-toe is more likely to be from the hips or the feet and not the tibia. So it tends to have a slightly different etiology, but it's interesting to evaluate. And this is showing how we rotate the legs to evaluate how much motion is. In this top picture, this is a patient that is in a face down prone position. and we can see how much the hip with the foot out, the hip is in. So this is showing you in this kind of 2 o'clock position that there's about 60 degrees of internal rotation of the hip. But look in the other direction, it barely goes past the perpendicular. There's maybe 10 or 15 degrees of external rotation, with the leg moving only to the 11:30 position, indicating that all the hip motion in this patient, this is an adult, is in the inward direction, and that's going to contribute to this problem. In the bottom photo, you can see that we have a little marker on the knee to show that when the person stands, their knee is very internal. The medial side of their knee joint is retracted back, and that's going to cause the legs to point in. And that's an indicator to us that the hip or the upper segment is involved, and that's what we're evaluating for here. We treat these conditions with a variety of things, including special shoes that you see there on the top left. And if the child is young enough, we may place them in a corrective bar. The corrective bar is here in the bottom of the photo, and the shoe attaches to the bar, and the bar holds the leg in a corrected position, so a force can be applied to the growing bone. Again, best done in younger patients. The younger, the better, and that's what these splints. That's what off-weight bearing splints is referring to. When they're not walking yet, 23 hours a day. When they're older, they may just wear it when they would not be walking. In some cases, we will put a high cast on, one above the knee, to correct these leg deformities. So we have shoes if it's foot, we have shoe and bar if it's leg and they're older, and we have cast if it's leg if they are younger. But casts don't work if you're walking, because you can't really walk in a cast, right? So casts are best in the infant who's not yet walking. And that's an AFO, and that's a plastic brace designed to rotate the lower leg out on the upper leg, and that's another option for treating these kinds of torsional problems. So you can see there's a lot of tools in our armamentarium to fix these. These are now the same deformities in older children, right? We were talking about infants and toddlers before. Now we're up to preschool and elementary school age group, and we basically move away from shoes, bars, and casts as kids get older because they're not very practical, and we have to move to more functional treatments that help them to walk straighter and to be less involved from their inwardness. And one group of conditions is called pelvic bands or elastic wraps. You can see one on a child's leg here. Here's one in a diagram. This is how they're wrapped. This is one way of wrapping them. This is another way. This is the wrap before it goes on. And those can be done to pull the legs out when they are very in, causing the child to trip, and they will walk straighter. They're cumbersome. They require a lot of on and off. They're not the easiest things to use, but they are effective. We also have special orthotics. This is an example of one that are used for in-toeing to try to get the foot to move, in the outward direction when they're walking. Next group of conditions are what we call angular deformities, which are basically your bow legs and your knock knees, legs that are in a C shape or legs that are knocked together. And they can be a cause for concern, and they may need to be evaluated and sometimes treated. Causes of bowing can be either in the knee or the tibia, right? The knees are apart. In bowing, there's a space between the knees, but the ankles are together. And when you see that, you want to look at where the apex of the deformity is. It seem to be at the knee, suggesting that that's where the problem is, or is the knee kind of in the middle, but the bone below it, the tibia, has the curve, and that would be more likely to be tibial barren. And there are different causes. There's a condition where it's growing curved at the growth plate, and that one's called Blount's disease, and that one, if it's present, is going to get worse over time because as it grows, it curves more. There's another condition that's called rickets, which is associated with a vitamin D deficiency. And if that's the cause, then treating the vitamin D deficiency can help it to get straighter. So if we see bowing, we evaluate it. We might take x-rays, we might take measurements. And then we need to look at the cause and decide the treatment based on the cause. There's some amount of bowing. That's what we call physiologic, meaning it's normal. There are certain ways that the infant leg presents in birth and young age, and it improves. Remember, I said that they improve over the first 6 or 7 years of life. So if they're in that window of the alignment that could be expected for their age, then we're not concerned. We just reassure the parents and maybe check them again in a year or whatever. But what we're doing here is differentiating between, is this a child with a little bit of curvature that's normal for their age, or is this a child with too much curvature that needs to be evaluated for one of these other more serious conditions? And we make that decision when we evaluate the child. And there's an example of some of the x-rays that might be taken to look at the angles. This is the opposite one. I mentioned bow leg and knock knees. These are knees together, feet apart. And you can see it here in the diagram. And here in an actual patient, knees together, it's sort of an upside down V. In the prior slide with bow legging, it was a traditional upward pointing V. And you can see that it's knees together and feet apart. And again, there are some ages where it's okay to be mildly knock-kneed. That's a normal part of development, but sometimes it's more excessive than that. And we want to look at if there's anything in the way the bone is growing that's making the knock knees worse and causing them to perpetuate. And we may have to identify and treat them. And also a lot of knock knee is associated with flat feet. And if it's knock knee associated with flat feet, they tend to get better when we treat the flat feet. So we treat a lot of knock knees by treating their feet, and by improving their foot alignment, we improve their knee alignment, because when the foot flattens, the knee knocks more. So it's kind of a cycle. Flatten your foot, knock your knees, reduce your flattening, reduce your knocking. So we see a lot of flat foot mediated knock knee. Here's some of those flat feet that I just talked about. And you can see from the picture that those are both pretty flat feet. One's a front-on view of one patient, and the other is a top-down view. But you can appreciate that the feet are lateral to the leg, outside to the leg, and very out or duck-like pointing in both cases. In this foot, and in the older child, the up view, this one, it's more out on the right side, less out on the left. You can see an early bunion deformity here. And these are kids who are often avoiding activity. They don't want to be on their feet a lot. They're tired. They look to take breaks. They're not always inclined to sports. And they may present to us with symptoms. And the symptoms may be things like I have there on the slide, that they don't want to be active, that they don't want to get up a lot, they sit a lot. And if they're young enough, not the age of these kids, they would be requesting to be carried, and may need to rest often. And as I mentioned a moment ago, they often avoid sports and other physical activities. These are some more flat-footed children. Again, there are children with flat feet that have no symptoms. There are children with flat feet that have the symptoms that I just mentioned, which are activity avoidance symptoms and laziness and all of those things. And then there's a whole other group of children who have classic symptoms from flat feet, because the muscles in the joints are being overused and they may be in pain. I see many children a week with pain associated with flat feet. And they may be clumsy when they walk. These are the ones who don't have pain. But these are the other things we typically hear from the parents. Oh, they fall all the time. Oh, they stumble. They may have early signs of certain deformities that we typically associate with older patients, like bunions and hammer toes, and you can see them here, right? The curves, toes are curling, the toes are deviating, toes are curling, toes are deviating. These will sometimes have an increase in their presence in young children because of flattening. And we talked about in-toe a little while ago, and a lot of in-toe leads to flat feet, and that's the problem of in-toe inwardness in the leg that persists. It causes the leg to rotate abnormally, and that puts a lot of pressure on the ankle and the foot, and that causes it to flatten, and then all of this stuff starts. So the so-called innocent in toe in the leg becomes a not so innocent flat foot when it compensates, and then, as you see in the pictures here, the problems start. Right? These are all young kids with foot problems, and we have a lot of concerned parents that want to see their kids not have these problems. And here's that third group of flat feet, and these are the ones whose feet are in pain. And these are not a small percentage, right? I see lots and lots and lots of kids with symptomatic flat feet. Classic symptoms: arch pain, ankle pain, tendon, the main tendon of the arch, the posterior tibial tendon, the back of the heel, the Achilles tendon, a specific type of flat feet, which is a fusing of bones in the rear foot called a coalition. A lot of what's typically called growing pains is associated with flat feet, that your muscles are overused and causing pain because your feet are flat, not because you're growing. Right? It generally does not hurt to grow. I'm not a big fan of that diagnosis. I don't diagnose the children in my care very often with growing pains. Right? What does that mean? It hurts you. It's hurting you to grow. So that's one of my least favorite expressions that I hear all too often from parents and other physicians sometimes. And other problems in the legs, knees, and other joints. And these are some other bones that can cause flat foot related problems, especially those with symptoms. An extra bone here in the arch area, it's called an accessory navicular. Here it is on an x-ray. Here it is clinically prominently sticking out. And these are problems on the bottom of the foot resulting from this is the accessory navicular. This is the mecuneiform exostosis, which is extra bone on the top of the arch. And these are often associated with flat feet. They may be causative of flat feet, but there are other parts of the condition that we have to manage. What do we do for these children? Well, there's many things we do, but one of the main tools we have are different types of what we call foot orthoses, which are inserts that go in the shoes. These are prefabricated ones, the yellow one in the small toddler shoe. And then these are various examples of custom foot orthoses. You can see a bottom view of one, a side view of another, and a weight-bearing view of a third one with the child's corrected foot on it. And these are made from casts and molds and careful prescriptions. And this is something that we as podopediatricians do as well or better than anyone in healthcare, and can provide children with the device they need to optimize their gait and their correction, and to really get them back to sport and pain-free sport and all the things that they need to do. Sometimes the flat foot is bad enough we have to go higher. These are devices that come above the ankle for toddlers. Sometimes we do these devices in older children, but particularly in the young child who may have delayed walking, who may have difficulty with early walking because of their degree of flattening, we need to sometimes control their foot and their ankle. And these type of devices called SMOs are often what we use because they give us the ability to not just move the foot, but to move the foot and the ankle. So this is a particularly useful tool in the pre-walker, new walker, delayed walker, and so on and so forth. Painful heels, another group of conditions that we see a lot in children. It's often after sports. Sometimes you have to find out the type of heel pain. Sometimes heel pain is related to flattening and pulling on the plantar fascia here in the arch area, and sometimes it's due to impact on the growth plate of the heel, which is called the apophysis, and that gives us a condition known as apophysitis, which is inflammation of this growth plate that I'm circling here. And these are the ages when that happens, and there are clinical exams we can do to determine what it is. In the flat foot kind of heel plane, we often see something called piezogenic papules, which are these little papules of fat that are emerging from pressure on the heel through the dermis and epidermis. So parents sometimes will come in concerned about these. These are normal. They're normal tissue, but they're extrusion of fat through the pericalcaneal walls. So those are two of the common causes of heel pain, and we do a variety of things for them, but heel orthotics is one of them, and we may treat them in other ways to get them off, get pressure off the heel, get pressure off the arch. But certainly, um, one of the more common symptomatic problems I see as a pediatrician is heel pain, particularly older children, preteens and teens. Moving along here, gait issues that are non-neurologic. These are some other things that can cause children to walk with difficulty. Short legs and long legs, which are more common than people realize. So we want, that has to be evaluated, because if the leg is short or long, it needs to be identified and treated, perhaps with a lift. You can see this orthotic has more material under the left side because it's shorter than the right side. You see all that material, and here from the side view, you can see that raised left orthotic. Here's a different orthotic where the raise is visible here in white, and we filled in the arch area to enable the orthotic to accommodate the lift. And those are just two different ways to do lifting. Also mention here that children, there are two legs and they're often very different. So one of the reasons we a lot of gait problems are not symmetric. One side is worse, one side is different. And here's an example showing you that the rotation of the knee of the femur is different from one side. This left side clearly goes in much more than the right one. Right, so that's an indication of a greater inwardness on this left hip, and that may cause them to have a different gait. And if I'm evaluating why is that leg in on the left side, and the parents are asking me, this is useful information, because it's going to tell me there's something going on in the femur, and I'm going to investigate it, and I'm going to decide what I need to do about the femur in order to treat it and make it better. So those are the simple causes of gait problems, but there are some kids that have more complicated problems, which may be neurologic in nature, right? As pediatric podiatrists, we see children that are not walking, delayed walking, walking with difficulty, who may have that walking difficulty as a expression of a neurological problem in their nervous system that isn't diagnosed yet. So we often are the gateway to helping that child get a diagnosis. We see the walking problem. We suspect, because of things we find on our exam, like weakness or low tone or spasticity or stiff tone, that it may be neurologic in nature. And when we see those suspicious signs, we're going to send the child on to be evaluated by a pediatric neurologist or other specialist, so that the problem can be identified and managed, treated, worked up further, and so on. Another big neurologic related pediatric condition that I see a lot of is toe walking, children who walk on their toes instead of with their feet flat or from heel to toes. And that comes in many forms. There are many what we call benign toe walkers, which they'll outgrow it. It's just an issue of stimulus, and they will eventually stop toe walking. But there are other children that toe walk for other reasons, and they may need help to block the toe walking pattern, and we may have to treat them with various devices to keep them down so that they get off their toes and start to develop more normal gait. And these are two of the treatments for those kind of problems. This is a so-called carbon fiber foot plate that goes all the way from the heel to the toes in the shoe so that the foot can't bend, and it keeps the heel down. And then this is an ankle foot orthosis coming all the way up below the knee to keep the foot at a right angle and to keep the foot on the ground so that the child can begin to learn to walk more normally. The idiopathic one is the one that's not a problem and will eventually grow out. And then these are just a couple of examples of things that we see that are really out of the ordinary, that do come in if we run a pediatric clinic. I call them zebras because they're very unusual, at least here in North America. Somebody with persistent foot pain without relief after consultation or treatment may have a condition known as CRPS, which is chronic regional pain syndrome. And these require elaborate workups. You want to make sure it's not something else. And these kids need a lot of support. There are often emotional and psychological issues. They often are difficulty weight bearing and walking, and they need a lot of podiatric and other support. And another possible cause are rheumatologic conditions, types of arthritis. And if we have kids who have pain not only in their feet but in other joints, we may suspect that this might be an arthritis. type of foot pain, and we might refer them for a pediatric rheumatology evaluation. And then you have really unfortunate trauma situations like this child in the photo who got burned by an iron. And that's before and after healing on the right side, after healing. And here's just a few final pictures of some of the things that I see. This is a very curved club foot. This is a what we call a skew foot, in the back, and then straight, and then in again in the front. This is a very severe spastic in toe. And there's another one of those AFO type devices, this time without the foot in it.
Dr. Volpe, do you mind if we stop for a couple of minutes just to answer some questions from the attendees, and then we can move on to the admissions portion?
Sure. You're going to do that portion?
Yes, I am.
Great. So yes, let me take your questions.
So we have a question from an anonymous attendee saying, at what point do medical cases become treatable by an orthopedist instead of a podiatrist?
Well, there's a lot of different. There's a lot of factors there. There are pediatric orthopedists that treat the bones of the whole body, including the foot. Some don't treat the foot at all. Some do. Podiatrists only treat the foot and the lower leg, basically. So there's overlap. There are things that they treat that we treat. There's things that we treat that they treat. There are certain things that they treat and we don't treat if they're higher up, and so on. There are pediatric podiatrists that do surgery. There are pediatric podiatrists that don't do surgery. There are orthopedists. Most orthopedists do surgery, but they may not be well versed in treating all of these other foot conditions that I mentioned. Remember, a lot of the things we saw in the slides were not orthopedic problems, so you wouldn't go to that. But there's definitely overlap, and there are cases, certainly when I see certain bony pathology in the leg, I may get my pediatric orthopedic colleagues involved because if they need a procedure or something more involved done in the leg, then I'm going to hand off to them to do it. So there's overlap and there are distinctions.
So we only have time for two more questions because we're running low. So we're just going to get through those and then move on to the admissions portion. Question number one, even though your main specialty is podopediatrics, do you typically follow your patients into adulthood? And if so, for how long?
Yeah, I have patients that I saw as children who have their own children now. But I think that's yes. Most podiatrists are generalists, and if they treat children, then they're going to move them into the adult portion of their practice. I'm a pediatric specialist. I see almost only children, so eventually most of them would age out of my practice. But yes, I think it's typical to continue with them because most podiatrists are not doing just children.
Okay. And the last question, I'm going to paraphrase it a little bit, but in essence, it is so during your presentation, you talked a lot about the importance of early interventions. Are there any ongoing research efforts or projects aimed at improving the efficacy of treatments for older children who may have missed that optimal intervention window?
Yeah, I mean, certainly we're always looking for new and documented and evidence-based ways to treat things, and there is research, going on, and at the colleges and elsewhere, and that we're actively involved in the literature, and certainly, the quest for new and better treatments is something we're always after, and research is important, whether we're doing it or reading it or documenting it, but that's how we learn and that's how we identify new things. So, absolutely.
Okay. And I know I said only two, but
Go
there's
ahead.
one question that is too good to pass up, which is how does someone become a podopediatrician? Are there options to be a DPM at a children's hospital or open a private practice aimed at children only? How do you go about that?
Well, I don't want to take too much time to go into all the details, but yeah, no, as I said a minute ago, most people will learn to treat children and treat them well, and it'll be a part of their practice. there are very few podiatrists that become pediatrics only specialists, but one could. I'm not, there are, typically the residency track is generally going to be more adult stuff and more surgically oriented, but there are certain programs that will allow you to get more of these orthopedic and pediatric training skills, and there are ways to get additional training after your residency in pediatrics and biomechanics areas. So, there are opportunities for it, and you can certainly, in a private practice, you can make it more pediatric if you wanted to. As a pediatrician, almost everyone I see is referred to me. So if you build up referral relationships, the kids who need you and me and us are out there.
Thank you. So, because we only have 5 minutes left, unfortunately, we have to move on to the admissions portion. So I'll just get started on that. So my name's Alan Steinberg. I said that at the beginning, but I'm the Assistant Director of Enrollment for NYCPM, and we're just going to talk a little bit about the requirements and some facts about us right now. So our requirements for an application are nearly identical to every other MD and DO program in the country. We require your official transcripts, your official MCAT scores, and 3 letters of recommendation or a pre-health committee letter. In terms of application deadlines, we are doing rolling admissions, but we also have a couple of deadlines throughout the year to help break up the semesters and the groups of students. So for our January program, which I'll describe a little bit more on the next slide, the deadline is December 1st. For the fall term, which is just the regular term that every other med school has, you have the priority deadline, which is April 1st. I don't believe that increases your chances of getting in. It just gets you your decision back faster. And the official deadline for fall, meaning that if you don't apply for fall by this date, you cannot apply for fall of 2024, is June 30th. Just some statistics. Our average MCAT score is 498. Our average overall GPA is 3.2, and our average science GPA is 3.0. And as you can see in the table over there in the middle of the slide, you can see your prerequisites are the same. Again, as I said, as any other MD and DO program, you just need 2 years of bio, chem, organic chem, and physics with labs and a year of English. If we could move to the next slide, please.
Oh, you want me to do it?
Yeah.
Sorry.
Yeah, I can't move the slides on your computer.
I got you.
So,
Sorry. It's
no,
late.
thank you. So
Been a long day.
our January program, I really think it's an awesome opportunity, especially for people who aren't exactly used to like the med school workload per se. Essentially what it does is it takes your first 2 semesters and splits them into 3 so that you're taking less classes per semester throughout your entire first year. Also, it gives you something that's completely unheard of in medical school, which is a summer break. Unfortunately, you only get 1 in the first year, but that gives you a lot of time to, get settled into New York, figure out where you're going to be staying, that kind of thing. We are also very, very proud to offer a Master's of Public Health through a dual degree program with the Mount Sinai School of Medicine. We have 7 concentrations for the degree, which you can see on the slide there below. The way this works is it's an add-on class, so it doesn't add any extra time to your degree. You just end up taking an extra class every semester, I believe once a week, that you can choose to take either in the morning, noon, or at night. And if you're doing a clinical rotation in a different state, you can take it remotely. We really do try to make it easy for you to attend these classes. If we could go to the next slide, please. Thank you. So here are just a couple of facts about us that you may or may not have known. We were the first podiatric medical school established in the US. We were established in 1911, meaning we've been teaching the science of podiatric medicine for well over 100 years. That has led to around 25% of all practicing DPMs in the United States being our graduates. So we're really proud of how far and wide our graduates have gone. Since 2018, I believe we've had a 100% residency match rate and placement rate, meaning that when you come here, you will get a good residency that will be good for you. And we are located essentially in the center of NYC. We're on 125th Street in East Harlem between the 1 train, the 4 train, the C train, and the B train, and the Metro North. So you could get anywhere in the city within 30 minutes. New York offers a essentially unbeatable patient population diversity, which allows you to see a lot of, I would say, statistically like once in a career pathologies while you're here, just because of the sheer amount of people that are coming into our clinic all the time. And we do have a full-time faculty in preclinical sciences, meaning they will be around for office hours when you're taking all those really hard prerequisite classes, and they will have time for you. If we could move to the next slide, please. So the QR code you guys are seeing on the screen right there leads to our website. If you fill out the survey at the very bottom, it will send you all the information you could need about how to apply, what the deadlines are, what documents you need. So if you are interested in applying, I highly encourage you to scan the QR code and fill it out. I just wanted to say thank you, Dr. Volpe, for joining us tonight. Your presentation was very insightful and incredibly entertaining.
My pleasure.
And no, the pleasure was all ours. And I wanted to give a big thank you to all the participants who came tonight. Thank you for coming.
Alan, there might be one or two more questions since
Okay.
you started talking. If you want to check quickly.
Um, so I see, thanks for asking my question. Does anybody have any questions before we end?
Okay.
Okay. So once again, thank you all for coming. I hope you guys all have an amazing weekend. And yeah, thank you, Dr. Volpe.
You're welcome. Good luck, everyone. Hope you enjoyed that, and hope to see you at NYCPM.
Yeah.